And how much time is it going to start?
Sir, within 5 to 10 minutes, we will start our program. Our speaker in some emergency, so once they will come and we
Okay,
will
okay.
start.
ठीक है, thank you.
Yeah, we'll inform you, sir. Yes, sir. Soon we will start our events. Since Dr. V.K. Singh is in operation, so within 5 to 10 minutes, he will come back. Teacher, why are you late? Student, mom and dad were fighting. Good evening, sir. Now it's yes, sir. Yes, your camera is okay, sir. Sir, sorry for inconvenience to all the participants. Since only 5 to 10 minutes will take time to Dr. VK Singh will come at this platform. Since he is in an operation, so very soon he will come back to us, sir. Please have a patience.
Hello.
Yes, sir. Your voice is coming, sir.
Uh, so, how many audience?
Sir, there is the 9 panelist members are there, and everybody has joined on the time. And soon we are going to start. So let me introduce yourself. Then you will set the context of MRA. Then discussion will start, sir.
Right. आगे पीछे कौन सा है? दूसरा नहीं है, आगे पीछे।
I am requesting to each panelist member to open the camera for a moment. Shall I start the program, sir?
Yeah, definitely.
Yeah.
So, what is the my responsibility, sir? Please tell me.
Sir, you are the moderator and you set the context of MRA and heart failure. Then I have shared one the PPT slides to you, and you will share the question answer and start the discussion with other panelist members.
So PPT is on the.
Already I have shared to you on WhatsApp, sir. If not, then I can share the PPT, sir. I will share.
You can better you can share the
yeah.
screen.
Yeah. So, good evening, everyone. Myself, Sri Ram Singh. I welcome you all on the behalf of SIPLA. Thank you, everyone, to join the session. Doctor, as you know very well, SIPLA has initiated the heart failure program for the heart failure knowledge sharing for medical practitioners. Heart failure is a global burden in the healthcare system. Sir, as you know very well, aldosterone play an important role in the pathophysiology of heart failure. Sir, all guidelines recommend the use of MRA along with beta blocker, ACE, ARBs, and diuretics. Sir, as you know very well, MRA is underutilized with only 40 to 60% of heart failure patients with MRA. Sir, if you see the study, 1 year mortality is high in HF patient, and it also disease modifying drugs like MRA should be initiated timely to reduce mortality in heart failure patients. With these words, I would like to invite, and we have distinguished speaker Dr. Virendra Kumar, and he is practicing in BK Heart Care Medical, and he did DM, and after the he did many interventional programs he did. So I welcome to Dr. Virendra Kumar to have a session and set the context of MRA and heart failure to in front of other panelist member. Please have a session, sir.
So can you share the slides?
You can share. You can only set the objective verbally, sir.
Only verbally.
Yeah.
Okay. Sorry for the delay. I joined little later, but
sorry, sir. One more thing. I request to each participant, can you open your camera? Because this is a very interactive program, so please open your camera. संजय सर अपना कैमरा खोल दें सर, अनलॉक कर दें कैमरा।
कर रहा हूँ, एक पेशेंट में ईसीजी करते खोलता हूँ।
Sir, please open your camera. I request to each participant, please open your camera. Yes. Yes, sir. Rajesh sir, Sanjay sir, please open your camera. Dr. Saxena, Dr. Soumit and Dr. Rohit Chaube.
एक ईसीजी करके खोलते हैं।
श्योर, चलेगा सर।
slide होगा ना
हाँ सर, आप प्रोग्राम स्टार्ट कर सकते हैं।
So I am audible. I am audible, sir, to all of
Yes
you.
sir. Yes sir.
So as you have introduced the topic, the heart failure is a global burden, and as our medical facility as well as the life expectancy is increasing with the time, and more and more prevalence of heart failure is increasing globally, because the life expectancy as well as the medical care is not improving in the underdeveloped country, rather than it is in developed country also. Therefore, this is going to be a major medical problems in the future, and there will be, as the medical facility is improving, the number of and the burden of heart failure will increase, as the longevity will increase, and the medical care of the, because you know the many of the risk factor for the heart failure is increases with the age, and the medical care further reduce the mortality of the risk factors like diabetes, myocardial infarction, valvular heart disease treatments. They are all prolonging the life, and therefore ultimately the patient or the person end up into the heart failure. So first of all, we should recognize what is the heart failure. There have been a lot of definition of heart failure, starting from the beginning of 2 to 3 decades ago. Where the heart failure was defined in so many ways: forward heart failure, backward heart failure, systolic heart failure, congestive heart failure, backward heart failure. So these are all symptomatic definition of heart failure. But now the most accepted worldwide the definition is when the heart is not commensurate with the need of the body, then at the normal pressure, normal filling pressure, then the condition is called heart failure. So once heart failure sets in, there are a lot of neurohumoral mechanism takes place in the body, and they ultimately leads to a vicious circle. Failure begets failure. Once the heart failure sets in, and the neurohumoral compensatory mechanism initially started in the body, so that tendency has to maintain the perfusion on the body. But many times there is overcorrection or overcompensation that will ultimately increase the burden on the myocardium, and the heart failure goes on increasing in the severity. So the heart failure, once it sets in, there are gradually progressive disease, and now we have so many therapeutic armamentarium which can reverse the remodeling or halt the progression of the heart failure, as well as it controls so many associated high risk situations. The heart failure is now we have a lot of therapeutic armamentarium. The recently called as an RNA, calcium channel, ACE inhibitors, aldosterone antagonists. These are the very beta blockers. So, but despite of all these, the heart failure has basically two concerns. One is its progressive nature. That is very important. For halting the progressive nature of the heart failure, that is very, very important, because once the heart failure sets in and goes on progressing, there will be every drop of the heart failure will further increase the progression, as well as increase in the sudden cardiac death. So there are two type of immediate cardiac concern, clinical concern of the heart failure. One is the progressive nature of the heart failure. So every approach has to be halt the progression by having the positive remodeling, as well as the sudden cardiac death. There are, because the sudden cardiac death is not directly correlated with the degree of the heart failure. So that is a different separate type of the risk that can be possible, that can be happen, or in the mostly even in the mild heart failure. So there are the two important aspects one has to be keep in mind while you are treating the heart failure. How much is the risk of progression of the heart failure, and how much the risk of the sudden cardiac death. So whatever the therapeutic armamentarium we have right now, as you know, the journey of treatment of heart failure started from the very beginning when the congestion in the body recognized, and the diuretics was the main therapeutic modality in the heart failure patients. So that, but this diabetes and digitalis now becomes an outdated right now. That is not going to improve prognostically. It may be a symptomatically benefit, but the heart failure progression or prognosis is not being affected with the common initial therapeutic modality like diuretics and digitalis. Rather, digitalis has been claimed not to be used. Otherwise, there are so many studies that has increased the mortality with the heart. But only some small subsets of the patients they need to be in digitalis induction in the treatment of heart failure. And of course, the diuretics is the main treatment when for the symptomatic improvement in the severe heart failure patients, but it is not going to improve the survival of the patients. So nowadays we have so many group of drugs like a beta blocker, aldosterone antagonism, and calcium ACE inhibitor, or now we have a ARNI, this is the latest one. These are all have a clinically proven benefit of prolonging the life and halting the progression of the heart failure. As far as the aldosterone, it is not only a diuretic, though it is in a potassium sparing diuretics, but it is not helping the heart failure patients only with the decongestion or their diuretic effect. Rather, they have another effect on the myocardium, like it is preventing the apoptosis, fibrosis, and further progression of the heart failure. So among the diuretics, aldosterone is one of the molecules which is not helping the patients of heart failure because of their diuretic nature or aldosterone sodium potassium balance as well as the renin functions. Rather, they have a direct action on the metabolism of the myocardial, and it can prevent the myocardial fibrosis. So this is a very, very important things that has been recognized so long back, but in the clinical practice, the use of aldosterone or aldosterone antagonism is not as it should be. Because of so many side effect profile of the aldosterone antagonism, what we have initially, like aldosterone, but now we have in a drugs very specific aldosterone receptor antagonist like eplerenone that has clearly avoiding and minimizing the side effect like hormonal side effect, gynecomastia and lipidobasis, but it has its original impact on the prevention of myocardial fibrosis and the positive remodeling as well as the prevention of sudden cardiac death. So if you call it the therapeutic armamentarium, nowadays the well standard recommendation of heart failure patient, any patient irrespective of their symptom or in a stage of heart failure, the person must receive the ARNI, beta blockers and the aldosterone antagonist. So this is the important modality of treatment. Now the aldosterone and every group, just say ARNI, aldosterone, they have their own independent benefit in the heart failure patient. And if you combine all these three group of drugs, like a beta blockers, provided it is tolerating, as well as the ARNI, as well as the aldosterone antagonists, definitely they all have their benefit in the progression of the heart failure patient as well as the prevention of the sudden cardiac death that is very commonly associated with the starting from the stage 1 heart failure to a stage 4. So, of course, the ACE inhibitor or the RNA, they have been very frequently used in the patient of heart failure. Again, there are some issue with the beta blockers, because the beta blockers, we know all in our graduate time that the beta blocker is contraindicated in heart failure patient. But nowadays, the beta blocker has shown very clear prognostic benefit in the management of the heart failure, because that is a very, very important group of drugs. The only thing is that the beta blocker should be started not in the acute heart failure patients, rather than in the chronic heart failure, and uptitrate the dose and adjust with the adjustment of the diuretics, so that the tolerance of the beta blocker should be good, and there should not be a complication associated with the, and it should be depending upon the stages of the heart failure. Person should have a slow up titration of the dose of the beta blocker, so that is definitely going to be benefit in the case. Similarly, with the aldosterone antagonist, if the patient is not tolerating the aldosterone, they can be used the selective aldosterone receptor antagonist like eplerenone. So these are the group of drugs which halts the progression of the heart failure, and it can improve the sudden cardiac death, which is commonly associated with the heart failure patients. But as far as the use of this wonderful drug, still it is underused in the regular treatment of the heart failure patient because of the issues of the side effect or the cost with the non-selective aldosterone antagonist. But once you use the selective antagonist, that is not very cheap. And regarding the treatment of heart failure, the cost of the newer therapy, still I will prefer that the neurocorticoid antagonists, they are cheaper compared to if you are providing the patient free frequent hospitalization, because the heart failure patients, they are likely to be get frequently hospitalized. So if you have a cumulative treatment of the heart failure patients, definitely the cost of the treatment of the single molecules is still in favor of the use of the molecules in the treatment of the heart failure. So in short or in brief, I will definitely say that the calcium ACE inhibitor, they are in the top use by the specialists, but still there is some fear of using beta blocker and aldosterone antagonist in the treatment of heart failure patients. But it should be used very frequently. It is going to be a very good and very effective clinical results in the management of heart failure. And I have a personal experience that if you are using these three important drugs, ACE inhibitor or RNA or the beta blocker or the aldosterone antagonist, definitely your patient is getting benefited not only in the symptom, but the chances of recurrence hospitalization. That is that way you can control the cost of the treatment. And not only that, many of times the patients may have some other associated risk factor which precipitates the frequent decompensation of the heart failure. But if you are using all these standard modality of treatment, patient definitely can maintain their status of the symptomatic status, and they can avoid frequent hospitalization. So that way you can curtail the cost of the overall treatment of the patients. The only risk with this use of the is the issue of the calcium potassium status, that one has to be little monitoring, required monitoring, as well as the aldosterone serum creatinine, or the whether, even though it is very less with the but simultaneously, if you are using some other drugs which can precipitate or we can increase the potassium level, we are in a solution, particularly when you are using the ACE inhibitor, one has to be little cautious of hyperkalemia. Some of the hyperkalemic situations, they are very prone for hyperkalemic. So one has to be very careful on using all these drugs. But it is not as we think about theoretically. Practically, we have never seen a very frequent association of the hyperkalemia in the heart failure patients. Similarly, the renal perfusion, serum creatinine level were also not very much issue, but definitely a diabetic patients or the very elderly patients or concomitant renal failure or the drugs with interaction that can aggravate the renal failure patients. These are the subsets of the patients where you have to be a little more careful according for the use of the aldosterone antagonist as far as the creatinine level is concerned and the hyperkalemia. And but the hyperkalemia, if you are monitoring the patients, it is not very difficult to treat if you can reduce the dose of or you can combine the potassium losing diuretics along with the aldosterone antagonist. The fear of the hyperkalemia is much less. So with this few words about the aldosterone antagonism, I will definitely say this is one of the important molecules that has to be given in each and all patients of the heart failure, irrespective of the stages of the heart failure, and in almost all patients, including the elderly or the patient is having mild renal failure. Because in the renal failure patients, the hyperkalemic possibility is slightly more. But if you are taking care of the hypersensitive patients, those who are very prone for the hyperkalemia, if they are not developing hyperkalemia in initial 2-3 weeks in time, then the patient is maybe tolerating the drugs unless there is some other associated condition in the future. So I definitely prefer this use of this ACE inhibitor or RNA or beta blocker, and the most important is the aldosterone antagonist drugs for the treatment of heart failure patients, irrespective of their stages, either in the initial stage or in the moderate grade of heart failure or the severe heart failure patients. So that is going to benefit, and it should be definitely underused. So by this type of the program of awareing the physicians, definitely I hope that the physician will get the more confidence of using all these newer drugs that is very well recommended in our the guidelines. So if you consider the guidelines therapy in heart failure patients, the aldosterone is one of them, because it is almost as beneficial as the beta blockers and the ACE inhibitors or ARNIs. But on top of that, the issue of sudden heart failure that happens most frequently in the initial stage, first or second stage of the heart failure patients. So this additional benefit of prevention of the sudden cardiac death or the arrhythmic death, the aldosterone antagonism has very proven efficacy in the management of heart failure. So with these few words, I encourage all the treating physicians that don't hesitate in using all these three standard tested recommended guideline recommended therapy of heart failure. One is the aldosterone and the ACE inhibitor or RNA. Second one is the beta blockers, and unless there is some contraindicated, or the highly selective beta blockers, if there is some contraindicated beta blockers, definitely, but it is not in the acute situation. Once the patient is stabilized from the acute decompensation, patient becomes stabilized, that beta blocker should be started initially in the lower dose and watch for the deterioration. And third one is the aldosterone antagonism, that is very important triad of treating the heart failure patients. And hope that many of the heart failure patients, if you use this triad of molecules in the heart failure patient, because diuretics and digitalis are now out of fashion nowadays. So that is the only few subsets of the patients they have that thing, but unnecessary diuretics use is not good for the heart failure patients. So the ACE inhibitor or ARBs or the ARNI or the beta blockers and the we three tried of using the heart failure patients. And but some of the patients they have some other progression and they are not going to land up to the class 4. Definitely the other modality of the like ivabradine and the CRT therapy, if the patient qualify for the indication of therapy or the assisted device just to bridge the therapy from the cardiac transplant, which is the final answer for the heart failure patients. Thank you.
So my slide is visible to you, sir?
Yeah, but little bit there are some picture coming inside.
Okay. So now that these are the few questions you can now all.
Yeah. So first question is what percentage patient approaches you in heart NYHA class 2? How many heart failure patient goes under diagnosis in India at the actually because in India because the primary healthcare system is very poor and the patient are very reluctant to approach to the doctors. So a stage 2 heart failure in the majority of the patients, they don't come unless they land up into the stage 3 and 4. And so in my view, the percentage of heart failure patient approaches to the physician in a stage 2 is very less. Majority of the patients, they come when they have a routine day-to-day activity impaired because of the dyspnea. So hardly very alert patients or educated patients, they have some sort of or very young dynamic initial patients, young patients, they can come in their stage 2. Hardly I will, if you can assess, hardly 10 to 20% patients of heart failure, they reach to the clinic for the treatment in a stage 2. So the 20%, 30% patients they remain undiagnosed in India at this stage. This is initial stage, but this stage is very, very important because the stage 2 does not have much physical restriction in the body, but this is the stage 2 where the sudden cardiac death incidence is very high compared to this. So that stage is very, very important. One has to pick up these stages. We have to educate the patient to not ignore this initial stage of heart 2 because at this stage, the incidence of sudden heart failure, sudden death is very, very high. So next question is, what are the diagnostic and prognostic tools used for the heart failure patients? So diagnostic tool in the heart failure is of course now the patient symptomatology as well as the echocardiography is available in the very I have to ask the questions.
Yes, sir. These are question panelist member can give the answer, and this is the discussion mode. Yeah.
So who is willing to answer this question number 1? Anybody? Anybody in the panelist? Anybody in the panel can answer this question number 1? Stage 2 heart failure patients remain undiagnosed in India, and why?
Because of patient, most of the patient is uneducated and he is not identify the symptoms. If the patient is not a very active person, if somebody is very active and then do the exercise, the day-to-day activity is compromised, and that's why the symptom 30 to 40% reach the clinic after the stage of 3rd and 4th. Basically, class 1 and class 2 patient restricted his lifestyle. That's why the patient is uneducated. Those are the most common things, and
So I will try to highlight at this answer because there is a very important the classification of a stage 2 NYHA class 2 by definition this is the symptomatic at ordinary activity.
yeah,
A stage 1 is asymptomatic on ordinary activity or very severe activity. A stage 2 symptomatic at a stage ordinary activity. Now this is the definition of NYHA classification. You remember that this is the textbook description of a stages of NYHA.
yeah.
But the ordinary activity is not defined. What is ordinary activity? So that's very important. I will try to make you understand here because this is a very important hidden issues one has to understand. Even the specialists, they don't define it. What is the ordinary activity? So the actual ordinary activity is what is your lifestyle? I will give you the example. Suppose a soldier who is involved daily, their life is a very hard activity, running, jumping, like this. So, and this much of the activity for a sedentary like a doctors, वकील, sedentary है दुकानदार, इसके लिए वो एक्टिविटी बहुत ही स्ट्रेनुअस एक्टिविटी होगा. पेशेंट को इतना जम एक सैनिक कर रहा है जो एक्टिविटी है, उतना एक्टिविटी एक जो सेडेंटरी हैबिट है उसके लिए वो स्टेज दूसरा हो जाएगा.
But depends the person to person activity. It depends on the activity.
So
if the somebody is climbing every day to floors.
So that's why I am telling you that the ordinary activity is not well defined in the textbook.
Yeah.
But the authority and the committee, they have classified it. They have defined the ordinary activity this way. So, as you rightly said, the uneducation and awareness of the health, poor knowledge, social issues, there are also many factors in our society that prevents the class 2 stage of hypertension to come into the physicians, and therefore they remain undiagnosed. As far as the percentage of it is concerned, I don't think anybody has a data unless they have a very a specific clinic, heart failure clinic, they can show. But roughly on day-to-day practice, everybody say, we can say only that the majority of the patients, they remain undiagnosed in a stage 2. I am not able to just put the figure because this putting the figure, it will be exaggerated in the response. So unless you have a data of your heart failure clinic, so those who are involved in the heart failure clinic, they can put some figure that this percentage of the patients, they are in stage 2, remain undiagnosed. But we can only say that significant number of the patients, they remain undiagnosed in NYHA 2 class heart failure. Am I right?
Yeah.
So the next question is actually something coming in between the picture. Yes. So what are the diagnostic and prognostic tool used for the heart failure patients? So that is very important.
So basic thing we are doing in the clinical basis, in our clinic, you just do the 2D echocardiography and the NT-proBNP. In most of the places, besides this, there are lots of things also used in the prognostic and diagnostic. But its common thing is the 2D echocardiography and NT-proBNP. NT-proBNP is a very good marker to prognosticate the patient. And 2D echocardiography, if you are doing the time to time echocardiography, you just measure the diastolic inflow pattern and the volume overload, PA pressure, MIP, PA pressure, and what is the reverse remodeling process of the heart. You can assess by this way in day-to-day practice.
Yeah. So as you know, the rightly said, the all the routine investigation in cardiology like X-ray, ECG, echocardiography, biochemical markers, they are all very important diagnostic tool for the diagnosis of heart failure. But one has to be very cautious about the whatever the heart failure situation we see in the echo is also having a very lot of variations. And that variation is inter-observer variation, intra-observer variations. So definitely in the borderline situation, when the borderline, there are a lot of factors there which you have to integrate, because we take the data on the echocardiography, which we nowadays understand that is the gold standard in assessing the heart failure patients, like prognosis as well as the diagnosis. But one has to be very careful that the echocardiographic ejection fraction is also have a very liquid sort of data. You know, has to be very and the echo itself have a very intra individual observer variations as well as the inter observer variations, as well as some limitations of echocardiography. But definitely to start with the ECG. ECG also a very important diagnostic tool to say that the patient is having.
Just use the QRS widening. And,
Yeah.
if you know the
QRS widening, QT interval, QT interval, and these are dynamic T waves. There are so many ECG findings. They also prognosticate the outcome of the heart failure patients. So along with this, because this ECG criteria of the assessment of the prognosis of the heart, they are very hard criteria, because the echocardiographic criteria many times it is very dynamic. It is swimming on the both the sides. Sometimes ejection fraction is 40%, sometimes ejection fraction is 100%. So like this, depending upon the therapy as well as the assessment. And so therefore the wall strain and all these things that is still coming up criteria.
In ECG, the two things is very important. You should know the rhythm and the QRS widening.
Yeah, right.
Yeah, a rhythm. If your patient is in AF, there your patient become weakened in case of heart failure patient.
Definitely. So the rhythm disturbance, either atrial or ventricular rhythm, they also prognosticate badly, because in the bad heart, the person have a lot of ECG changes in this. Very well, rightly said that. So the X-ray ECG, the size of the heart, ECG changes that you have shown, echocardiography, as well as the biochemical markers, along with the imaging technique like MRI. There's all the myocardium and myocardial strain signal. They're all the interesting factor for the arrhythmia diagnosis by Holter. So all these important diagnostic tools, they have prognostication in the curve. So the third question is, are the parameters potassium level, creatinine, EGFR tested before and after initiating MRA?
Yeah, we should care all the parameter if you are using the MRI, because most of the heart failure patient have some renal dysfunction and diabetic, and using the AC inhibitor, ARNI, so the chances of hyperkalemia is very high in these cases. So the regular basis of measurement of potassium is GFR is very important, because you are all the heart failure patient, most of the heart failure patient using all these potassium increasing drugs, ACE inhibitor, ARBs, and the ARNI, and if you are giving the MRI. So the chances of hyperkalemia is very high, and the most of the low GFR in cases of heart failure ejection fraction 25, the kidney is also compromised. So regular basis is the GFR measurement, and the potassium level is very important to measure in all these cases.
Right. So one thing is if you start the MRA in heart failure patients, a week or 2 weeks time, you must first assess what is the tendency and how much it is rising the creatinine as well as the potassium level.
Yeah,
If
yeah.
it is increasing by 25%, we should be little more cautious and using frequently. And definitely there are some cutoff value like 5 milliequivalent potassium as well as the creatinine. They are the situation where you have to withdraw the MRA or you can change the dose. So the next fifth question is at what percentage you use MRA for heart failure patients?
So we are living in the third world. At first, the cost is very effective in our country. So we start because the most of the patient of heart failure is not afford the costlier drug like AR9. So basically, we start the diuretics, loop diuretics, and then add the MRA. So the first line of management you are using, because this is the potassium sparing diuretics. So you most of the clinicians use the with loop diuretics with the potassium sparing diuretics. So in my way, according to the our country situation, the you are using the about 80 to 90% of cases.
Anybody have some another opinion?
I think, sir, good evening. I think we should start as early as possible. Spironolactone group of drugs. I think, as you earlier said in the lecture also, ACE inhibitor, beta blocker, and spironolactones, they are must in the treatment of heart failure. If we don't use these drugs, ultimately the cost of hospitalization and other complications would arise. So I think we should use it as early as possible, probably at discharge, and consider it in the treatment. I don't think it is.
At first, we should understand the MRI role of MRI in heart failure. The role of the MRI in the heart failure is just protect the remodeling. So just reverse
Yes.
the remodeling process of the heart.
So yeah,
And
so cardiac
yeah,
remodeling plus.
this is the cost wise. If you think about the cost wise, our country is a very poor country in regarding the treatment. So electron cost is just around 1 and 2 rupees. And this is the very good drug to prevent the cardiac failure in the our community, low economic, socioeconomic community. Most
Absolutely,
of the so this is the first line management you are using in the just poor patients, the diuretic loop diuretics with the spironolactone MRI group. So this is the important for regarding the reverse the remodeling process.
yes, sir.
No, actually, I will little put some another way of this proceeding. It is not necessarily that you should use the receptor specific MRA, because even if you using non-specific, you are getting the benefit of that, and that is not very costly. And if you are restricting very tested treatment in your prescription, avoiding all these auxiliary medication in the prescription, definitely that is not going to too much burden to the patient, even if they are poor patients. And definitely, you see that the frequent hospitalization, frequent clinic visit, and all these things, that is everything is have to pay by the pocket of the patients. So you can use this aldosterone simple, that is not very costly. The specific receptor antagonist, that is little costly, that only you can use when the patient is not going to tolerate the side effect of the MRA. So that way you can reduce the cost and you can pass on the benefit of MRA in the heart failure patients. So I think you must be agree with this. So now
According to guideline is okay, but I am just talking about the day-to-day practice things, nothing else.
right.
Guideline is the different thing, but you are facing the practice is the different thing.
Okay, so the
Yeah.
fifth question is, when do you consider starting MRA in patient with the along with the ACE, ARB, and beta blockers?
I think, sir, you have already answered this question, sir. We have already
Oh,
discussed this, sir.
I think there is no issues are right. You have already said.
Yeah. Yes, sir.
What is the next question? Sixth. Any sixth questions? Yes, that is also very important, and we have discussed about when do you prefer using propranolol or a spinolol on a specific patient profile. So, any specific patient profile you prefer?
Patient is having some sort of side effects, for example, gynecomastia and feminization, and all those problems are coming. Then probably that is where it is superior, sir. Other than that, I think.
And of course, the pocket of the patient.
Spironolactone is better, I think, other than in comparison to alprazolam. Probably it is more specific. That is why.
Gynecomastia is common in the.
How often do we see, sir? How often do we see that? I don't get to see much with spironolactone.
As regarding about the side effect of gynecomastia, the finerenone is a good choice. It is a non-steroidal MRA. So, in respect of the side effect of gynecomastia, you can use the finerenone.
Absolutely.
Yeah.
Yes, sir. That is where probably you use it, sir. Otherwise, I think most of us are using spironolactone, sir.
Yes, sir. But tebulonin is also causing the gynecomastia, but as compared to spironolactone, is
less
very
in comparison.
Right. So I think this is well accepted. Now the question number 7, Chibutis. So what is the preferred dose? How it is dose titration in the
start
25 to 100 mg.
You can start from the 25 and increase up to 100 mg. But mostly we prefer to use 25 to 50 mg.
Yes, sir.
So what percentage of heart failure on MRA develop hyperkalemia and they require discontinuation of the treatment?
Basically, if the patient is a renal profile and renal profile is not good, GFR is low, and patient is a nephropathy patient, so then just stop this drug. If the patient is not a renal patient and the hyperkalemia, you think about the patient is taking the bad diet. Bad diet regarding he is taking the potassium rich diet. So use all these things. You should consider all these things, and then you titrate the dose of the MRI.
So, will you take the decision of discontinuation in the case of hyperkalemia if it occurs?
Yeah, tangentially, you can think you just stop this.
Probably you can use.
And you just find out the reason of the hyperkalemia. If the patient is not taking other potassium retention drugs, and patient food is not taking the lots of hyperkalemic foods, like he is not taking a regular basis of the high amount of food. So these are things you should consider, and then accordingly you take the judicially use of the MRA.
So definitely the drug modification, dose modification is required in a concomitant drugs, renal status, cardiac status, particularly any sinus node disease situations, which is very lethal sometimes.
Yeah, so, recently data even also revealed that the potassium MRI you can use in the mild to moderate renal disorder also. That prevents the renal fibrosis and the sclerosis. So you can use the cases of mild to moderate renal disease, even in stage 3.
Because this the advantage of this mechanism takes place in the renal also. So that is.
So reduce the proteinuria. If the patient proteinuria is very high, the chances of aldosterone rises in your body very high. So this drug also prevent the albuminuria. So just reduce the aldosterone and protect your heart also, because the aldosterone is directly regulate your remodeling process.
So can you tell in how many patients definitely it should be hold not to use, and what are the how they can manage those type of patients? So how many patients you come across in practice where even the low dose is not acceptable and the drug has to be discontinued? So what are the approximate percentage of this group? And then how you can plan for management in such patients?
Basically, the patient potassium level is high, and you just see the patient reveal that the QRS is widened, and patient is symptomatic, some become sinus arrest, and the picture of hyperkalemia I saw. So judiciously, you just stop this drug, admit the patient, and give the hyperkalemia treatment. And if the patient is asymptomatic, the ECG is no any sinus arrest, no any QRS widening. So you just stop this drug and just review after the 4 or 5 days and 7 days patient and do the potassium level and restrict the food,
So how many
hyperkalemic food also.
and how many of you will agree that if the patient is not tolerating anyway, even a smaller dose, and you have to discontinue, will you like to continue in the lower dose along with the potassium chelating agent orally?
Potassium chelating agent sometimes is beneficiary, but if the patient is today he is taking the drug and the potassium levels is very high, so you can give the potassium chelating drug. But if the patient is symptomatic, you can manage with the other, with the calcium gluconate, your 25% extra with the insulin and soda bicarb. So you accordingly plan the patient according to the symptoms and clinical practice, ECG finding.
Right. So is there any other question next? Do you have any other question? Yes. So question number 10, in the clinical practice, how early an MRI initiated for the management of heart failure? How early this drug should be used? Yeah, started.
Clinical practice and according to the, if the patient is a heart attack patient, is the MI patient, you, as early you can use the MRI, because in MI patient the remodeling process is early initiated. So if you are using very early aldosterone, that will get benefit to the patient.
Because we have seen in the trial that the benefit of this direct has started very early compared to those who have not received this MRA. So therefore, the cardioprotective benefit of this MRA is started from very early. Therefore, it should be started as early as possible.
As early as possible.
Right, sir. So now the next question is, at what age of heart failure diuretics and MRI both are needed?
Torsemide with eplerenone or spironolactone plus torsemide depends on the cost of the patient.
Yeah. So at what stage of heart failure patients both diuretics and MRI both are needed?
You should start the NHI2. You should start the NHI2 patient.
If signs of failures are there, probably we can use diuretics as well. Swelling of pedal edema is there, probably then we can add diuretic as well. It will benefit, the combination will benefit the heart, sir. Generally we start, somebody who's in failure, we generally add loop diuretic as well to spironolactone, sir.
So mostly class 4 patients, those who are having some congestion all the time.
Breathlessness, yeah.
And then they both diuretics as well as the MRI should be needed, and that's stage 4 of the heart failure. So question next question is, what is preferred choice of therapy? Eplerenone plus torsemide, spironolactone, and spironolactone and torsemide.
It's the same answer. Japlonin is the torsemide. What stage? You already answered this question.
Yeah. So for all the parent members, in your practice, any other indication apart from the heart failure where MRI is used?
Yeah, I already discussed about
The
the
renal.
renal dysfunction in case of and diastolic failure also. In case of diastolic failure and a resistant hypertension
Hypertension.
cases, you can use this.
Primary hyperaldosteronism, Con syndrome.
Right.
Seen less, sir, but resistant hypertension
You
basically,
are
sir.
resistant hypertension is the one of the, and you can use in the diabetic nephropathy patient in the stage two renal disease, and the heart failure. These are the three indication to use the MRI.
Right, sir. Thank you. So the next question is, what scientific initiative would you suggest to increase the awareness among the general practitioners? What scientific initiatives do you suggest to increase the use of this drug in the heart failure patients?
Among the CPs, what is the CPs? CIPLAs. What is the CPs?
I think clinical practitioner, sir.
Physician.
Clinical practitioner. Oh,
Clinical
sorry.
practitioner, I think.
Yeah.
What suggestions do you think is a scientific initiative?
You can advise in every heart failure patient in our country. If the patient is symptomatic in class 3 and class 4, you can use this drug.
And probably, sir, Cipla can cut the cost of alprazolam, sir. That is the suggestion we would give to Cipla, sir. At some point, probably they can cut the cost.
Of course, what we are doing, and company people are initiating that company people should have a figure focus on the cost as well as we are should focus on the benefit of this molecule. I think jointly doing effort in a such similar way, definitely with the time the use of MRI will be increased among the physicians in the management of heart failure. Thank you, sir. Thank you. Welcome.
So, sir, it was a very wonderful and very informative session that he discussed about here. And now we are open to questions. You can unmute yourself. If any doubts is there, then you can directly ask two questions to Dr. Biren Kumar BK Singh, sir. Please unmute yourself, sir. Now, the single in the last, I would like to request each one of you can kindly put your camera on so that we take one fixed group photographs. I request to each participants. Dr. Saxena, Dr. Sanjay, if possible, can you put your camera on? So there is no issue, sir. And thank you, sir, for your valuable time and efforts. I also thank to all panelist members and audience. So, if anything, now with these words, I would like to hand over this session to Dr. BK Singh. Now we are in the closing time, sir.
Right, sir. Thank you.
Thank you very much, sir.